Rehema Nanyonga is the mother of this 3-day-old baby at Mwesigye Health Center 4. They were rushed here after the newborn developed severe breathing complications after birth.
I gave birth to my baby very well, but it didn't cry. I was then referred here from the health center where I gave birth. We reached here when the baby was very sick. I didn't even think it would survive, but when they put the baby on the machine, there was an improvement.
At the facility, clinicians immediately placed the baby on oxygen therapy, stabilizing her breathing and saving her life.
Today, I was told if the baby suckles, we will be discharged.
Rehema's baby is among more than 15 infants admitted here every month who require oxygen support to survive. Harrier Nanduga, the senior nursing officer, says since the establishment of the neonatal unit, more than 100 newborns have survived what would otherwise have been fatal birth asphyxia.
No longer referring neonates to Kawempe, Gombe, where we used to refer them, and we are caring them from here. It has reduced the expense on patients.
Birth asphyxia, the failure of a baby to begin or sustain breathing at birth, remains one of Uganda's leading causes of neonatal death. It accounts for between 28 and 48% of newborn fatalities, with an estimated 54 cases per 1,000 deliveries. Nanduga attributes the sharp reduction in mortality here to a new innovation that guarantees oxygen supply to the neonatal unit 24 hours a day.
So we get like 200 to 250 deliveries a month, and at least 10% of those children may need oxygen. Some are severely weak because they have delayed delivery, but some need oxygen because of their conditions. And having this plant here, it has eased our work.
The technology, known as Free O2, short for free oxygen, is an innovation developed by Free O2 Foundation to reduce newborn mortality in low and middle income countries.
They worked with a manufacturer in Germany to come up with a concentrator that could provide oxygen regardless of what was happening with the power. So perhaps you've seen it here. I know you have solar, so you may not have, which is really great as part of this program, but the oxygen continues to flow. So the room can be dark, but there's absolutely no change and no need for a health worker to interfere in any way, drag a cylinder or worry that the child isn't receiving that continuous oxygen. So that was one of our big major innovations. But we know, and everyone knows here, you can't just put a piece of innovation or a piece of infrastructure into a facility. You've got to look at the whole system and ensure that it really works. And the first thing that we looked at embedding into what we do is capacity building of health workers. So we do the hypoxemia alongside the Ministry of Health, hypoxemia management, including diagnosis and therapy. And we also do biomedical and technical capacity building. So we feel those two things are really, really important to ensure that the system continues to work. So it's not just putting it in, and it continues to allow oxygen to flow.
Introduced in Uganda in August 2025, 98 automated oxygen systems have since been installed in 78 health facilities nationwide. The system operates with or without electricity, a major breakthrough in settings where power outages are common.
700,000 children dying every year over preventable causes, and a huge sum of them are actually due to what we call birth asphyxia. Children who have been deprived of oxygen at birth are almost a half of this percentage of those that die are actually secondary to lack of enough oxygen at birth. And also, among these that die, many of them are below 28 days. They are called the neonates. So our neonatal mortality is still way above the SDG target of 12 per 1,000. We are at 22, so we still have a long way to go. And one of the most common causes is insufficient oxygen. And so for us, these systems being at facilities where most of our deliveries happen is a plus. In as much as the government, together with partners, have invested in bigger infrastructure at the regions, at our tertiary facilities, we have oxygen plants. We need these innovative systems at our lower level health facilities to see to it that we save more under fives, and this will improve national targets. We are already seeing improvement because the health workers quickly connect the babies to these systems.
The concentrator filters ambient air and delivers up to 95% medical-grade oxygen directly to neonatal beds. Engineers say the system can also be monitored remotely, allowing faults to be detected and resolved quickly without interrupting care.
It has a backup that can be able to supply power without electricity. So some of the major issues that we find with this system are what we call fluctuations in voltage. The other challenge we have is the concentrators. These oxygen concentrators have what we call a sieve bed that is able to separate nitrogen and oxygen. And when these sieve beds drain or deteriorate, they are unable to deliver high purity oxygen that is almost at 96%. So the purity can go as below as 43% or even 21%. Such a purity does not help with the children who need oxygen. So the maintenance model we use is a swap and go model, where we carry a functional component or a concentrator from our hubs. Then we come to the facility and only swap. So that has helped us to reduce maintenance time at the facility, but it has also reduced the downtime of the oxygen systems.
During their visit, the Foundation's leadership met Ministry of Health officials to discuss long-term sustainability once external support phases out.
If government wanted, let's say, to buy a system to put in an additional facility, we're looking at a range of about $10,000 to $15,000 for each facility, and that was without maintenance and support.
When you're calibrating the requirement, the oxygen requirement of this facility, you need to look at the catchment population and be able to come up with what the requirement will be. So in this advancement that we're working on, we want to come up with a prescriptive standard that we say this free O2 mechanism will be able to deliver oxygen for this level of care, Center 3 or community hospital. And once that has been developed, then going forward, the government will take it on from there.
Clinically, birth asphyxia is often linked to prolonged or obstructed labor, maternal infections such as malaria or syphilis, fetal distress, and teenage pregnancies. In these moments, rapid intervention determines whether a newborn survives. For facilities like Mwesigye Health Center 4, continuous oxygen supply is no longer a luxury. It's the difference between life and death. Walter Mwesigye, NTV.